Now we call upon Dr. Ashwini Guge to present on cortical blindness in COVID-19 pneumonia, a rare case report.
Good morning, everybody. Today I'll be presenting cortical blindness in COVID-19 pneumonia, a rare case report. The WHO declared the outbreak of COVID-19 global pandemic in March 2020 after widespreading of COVID-19 pneumonia cases. At the beginning of the pandemic, many physicians reported cases of conjunctival congestion and irritation in Wuhan, China. It has also been reported, in addition to the respiratory tract infection systems, patient can also have neurologic signs and symptoms like acute cerebrovascular disease, polyneuritis, encephalitis, and encephalopathy. In this report, we describe a patient who had bilateral cortical blindness as the presenting feature of COVID-19 related pneumonia. The case report, a 56-year-old diabetic male presented with the chief complaint of bilateral sudden painless vision loss associated with fever and cough since 2 to 3 days. On examination, both eyes were pseudophakic with visual acuity of light perception and PR was accurate in both the eyes. Pupils were round and there was no RAPD. Intraocular pressures were within the normal limits and other anterior segment was normal. Fundoscopy showed mild NPDR changes. Patient had mild altered sensorium and vitals were stable. MRI brain orbit showed acute non-hemorrhagic infarct in bilateral occipital lobe adjacent to the midline, suggestive of posterior circulation basilar artery or PCA territory infarct, intraparenchymal hematoma in the right frontal lobe. HRCT showed irregular and patchy ground glass opacities with intralobular septal thickening. COVID test was done and patient was RT-PCR positive. CSF, there was no pus cells or organisms. CRP was raised. There was raised serum ferritin and D-dimer levels and patient had raised RBS level. MRI picture showing acute non-hemorrhagic infarct in bilateral occipital lobe adjacent to the midline and intraparenchymal hematoma in the right frontal lobe. Irregular and patchy ground glass opacities were present in the intralobular septal thickening. Fibrocalcific changes were noted. The patient was immediately shifted to the COVID-19 setup and was managed there with antiplatelets, statins, IV antibiotics, IV dexamethasone, vitamin C and zinc supplement. Blood sugar was managed with subcutaneous insulin. Patient was discharged after stabilization and negative RT-PCR and was kept on follow-up in the ophthalmological setup. The visual acuity improved gradually, which at 3 months was hand movement, at 9 months it was 636, 624, and at 15 months of follow-up, it recovered to 612 and 69 from PLPR. So discussion, this patient presented with the chief complaint of sudden bilateral vision loss. After thorough examination, both anterior and posterior segments, which were essentially unremarkable, a diagnosis of cortical blindness was made and patient was urgently scanned for a cerebrovascular accident. Patient was then tested positive for COVID-19 and managed accordingly for PCA and diabetes as well. Visual acuity improved gradually and slowly over the period of 1 year. As seen in our patient with pre-existing risk factors and a confirmed diagnosis of COVID-19, thrombotic events occurred which led to devastating visual outcomes secondary to occipital lobe ischemia as evidenced by neuroimaging. Over time, there is clear evidence that thrombi are a major cause of multisystem organ dysfunction in critical cases. Elevated levels of C-reactive protein and D-dimers directs towards a high inflammatory state and abnormalities with the coagulation cascade. Despite this, our patient presented with the cerebrovascular complication in the early stages of his illness. COVID-19 infection has been associated with prothrombotic effects due to virus-induced cytokine storm that can activate and upregulate the coagulation, which triggers the formation of a thrombus that may lead to ophthalmic artery occlusion, central retinal artery occlusion, central retinal vein occlusion, and others. Along with progressive respiratory system involvement, central nervous system has also been reported to be affected due to the affinity of the virus towards the ACE2 receptors that may result in meningitis, encephalitis, or stroke. Also, SARS-CoV-2 can engage the endothelium, increasing the permeability of the blood-brain barrier and leading to encephalopathy, encephalitis, and thrombosis. So in conclusion, I would like to say visual loss during SARS-CoV-19 infection is a rare finding. Despite the low incidence, many cases have been reported in the literature. COVID-19 related thromboembolic events can cause significant functional deficits, which may include debilitating visual loss. Therefore, as ophthalmologists, COVID-19 should be considered in patients who have developed sudden visual loss, as it can be the presenting feature of the infection in some instances. Clinicians should be aware of this uncommon event to help contribute to an interdisciplinary approach to an appropriate management. Thank you.
Thank you. Did you do a repeat field testing when you have a visual recovery?
No, ma'am, the patient denied it actually.
Because the incidence of stroke associated with visual loss was high in the in the pandemic era.
Yes, ma'am.
But I think it was, I can't say it is an unusual, but it was, we had seen
should
more
have been
common
done.
presentations because mostly the patients were hospitalized for the acute condition, and later when they presented to the ophthalmologist, it was during the pandemic only they developed the thromboembolic episode. So unusual presentation as
Actually, ma'am, all the literature that has shown the visual loss was always came at a later stage of the disease, and the patient was debilitated and hospitalized. Here, the difference was the patient came with the chief complaint of visual loss, and he was in a very early stage of his disease, and there were no other symptoms despite just a mild
so
cough
it
and
was
fever.
the vision loss as the presenting feature of COVID rather than the patient presenting with COVID.
Yes.
So would you rephrase it that way?
Yes.
But there was bilateral or occipital infarct, na?
Yes.
So it could have been a thromboembolic event,
Yes.
then it could have been a basilar artery.
Yes.
Cannot be a bilateral PCA are affected. There was no neurological sign, no brainstem sign.
Yes. Sir.
There was no brainstem sign.
No stents. No, sir.
Because it cannot be a bilateral PCA infarct. Usually it is hypotension or spasm which causes that your PCA infarct bilateral.
Yes, sir.
But
These
here
are
the thromboembolic event, because the frontal hematoma you have shown, and
Yes.
even the infarct, they were asymmetric. I was seeing the imaging.
Yes.
Do you have any MRI report before the incident happened?
No, sir.
No.
Patient did not have any previous history, or as such he was only diabetic, and he had no any past history, so we do not have any reports of the previous medical history.
So D-dimer was raised.
Yes.
And what about fibrinogen?
Uh,
You're not knowing. Okay. Yeah.
yes, sir.
You have a recovery of the visual acuity, but your field effects will be the most telltale evidence of what you have a persisting deficit.
Yes, and we insisted the patient, but the patient did
Or
not.
at least a central fields or a confrontation would have had. It's a basic thing. Okay, right. Thank you, Doctor.